Yes, I think it's a very hot topic, and this topic of suction, because we have to talk about irrigation, aspiration, suction, pressure. It's a very complex topic, and I think actually we are just at the beginning of this concept, and we will have much more sophisticated technology coming to regulate this problem of irrigation, suction, and pressure, because it's impossible not to take all this information at the end to have a good irrigation. Uh, Before I start, I would like just to make two comments regarding the previous talk, but also the general comments. Actually, nobody knows if what is the more dangerous in terms of intrarenal pressure, if it's to keep high pressure constant, or if it's to produce some peak of pressure regularly. Nobody knows exactly what is the more dangerous. Somebody said that if you increase too fast the pressure into the kidney, there's a big risk to produce a fornicial rupture, and then you have some urinoma. But you need also to consider that this urinoma is what we can see during a regular renal colic. The system cracks, and then we have some kind of a urinoma, and it's in fact a solution to decrease immediately the pressure into the kidney. And this is probably something that we need to keep in mind. Because if you crack the system and you have this kind of urinoma, you also decrease the possibility to increase the intrarenal reflux. And the intrarenal reflux is probably more dangerous than the urinoma itself. Um, and if you keep constant the pressure into the kidney and you have no cracks, there's probably more reflux into the parenchyma and maybe more risk. I can just tell you that we are doing some evaluation actually in the lab. We are using a specific marker uh, that they are able to integrate into the renal parenchyma if we can generate reflux. If you generate reflux, the liquid together with this marker, the marker is going into the parenchyma, and it can stay. And then when we do some histologic evaluation, we can see if it's present or not. I can tell you that if we do some regular increase of pressure, so just some peak of pressure regularly, we have much less marker into the parenchyma compared to if we increase the pressure and we keep the pressure constant. And then the parenchyma is full of marker. Something interesting. And then we need to know if it's a problem in terms of complication or not. But interesting to evaluate this point. The second comment is regarding this specific patient that Ben demonstrates with this super high pressure into the kidney. And Ben mentioned that this young guy was a very muscular guy. Um, I think don't keep in mind the message that muscular guy, they have more high pressure. This is not the problem. Muscular guy, most of the time, they are very tight ureter, meaning that the outflow is very limited. If you put an endoscope without an access sheath, the outflow is super limited. So if you are using a high pressure system to irrigate for the inflow and you have no outflow, then you generate this high pressure. And that's what Ben demonstrated in this video. He was using this 150, 200 millimeters of mercury pressure bag. So he irrigate with this pressure, meaning that if you have no outflow, the pressure will go up to 200 and then it stops to irrigate. And that's the explanation. So in such a situation, if you have a very tight ureter, knowing that the outflow is really limited, what you need to do is to decrease the inflow pressure, meaning that you need to keep like a gravity bag to 40 centimeters. Doing that, you cannot go more than 40 centimeters into the kidney if you have no outflow, or at least you give the time to the kidney to evacuate very slowly the irrigation, meaning that at the end, in such situation, you will take much more time to do the surgery. You need to be more patient, but you cannot keep this high pressure to irrigate to produce the inflow. Huh? So be careful if you are using this super high pressure system to irrigate. The problem comes when the outflow is limited. Until you have no problem because you have an access sheet or because you have a suction system, you increase the outflow, okay, you can irrigate with much more pressure. But if the outflow is limited, you cannot irrigate with high pressure. You need to respect low pressure, meaning 40, 50 centimeters. Exactly what we do when we irrigate for bladder tumor, when we resect, or for prostate. I think it's very important to understand this point. So now, let's give you, I will give you my opinion regarding suction aspiration. And what I'm thinking is the ultimate solution. So I mean what we will maybe see in the very near future. That's my disclosure. I'm a consultant for those companies in some years. I'm also the new chair of the EAU Endourology, and you can see the board, or the new board of this section for the European Association. And again, I like to start this talk by giving this very well-known sentence from Ralph Klemen, you know, when he said from knife to needle to nothing. That's the definition of endourology. And in fact, we can say that it's from open surgery to PCNL and to flexible ureteroscopy. And that's what we do more and more, actually. We are using more and more retrograde intrarenal surgery. If we look at the evolution of technology since a long time, and especially in the last 25 years, we have to admit that most of the improvements are on the sides on the topic of flexible ureteroscopy in terms of new endoscopes, in terms of new laser, in terms of suction system. You have seen this evolution of technology. Of course, shockwave lithotripsy is still okay, it's still present, and it still play a major, a very important role for stone treatment. And again, PCNL is also very important. We need to do PCNL. But again, if we look, what about the improvement in the last 40 years? Maybe miniaturization, of course. We are using smaller and smaller instruments. We change the position, supine versus prone. What is really the benefit? Nobody knows exactly. But at the end, you know, if we look at shockwave lithotripsy and flexible ureteroscopy, we have no clear improvement of stone-free rate. We do more or less exactly what the colleagues were doing 30 or 40 years ago. So we need to admit this. In parallel, we need also to admit that flexible ureteroscopy in the last 20 years was really improving a lot in terms of indications and slowly replace shockwave lithotripsy. And maybe soon it will also replace most of the cases that we are treating today with PCNL. Just a slide to show you what we are doing in my country, in France, just to show you that actually flexible ureteroscopy represents 75% of the procedures for stone treatment, and shockwave lithotripsy 25. So it means that PCNL in my country represent less than 1% of the indications. And this is maybe a bit specific in my country, but I think that's what we can see in many, many countries, actually, that we are doing more and more flexi. We still do a lot of shockwave, and PCNL is decreasing more or less everywhere. It's also the same into the guidelines. You know, we can see that flexible ureteroscopy is more and more present in all indication, We have also specific recommendations for stone between 2 to 3 centimeters using flexible ureteroscopy. Can you imagine 10 years or 20 years ago, nobody was talking about flexible ureteroscopy in this indication. Even Ralph Clement, is giving such kind of talk regarding the death of PCNL. It's a bit controversial, I agree, but it just means that PCNL, even is very important, is losing probably some importance. So if we think about the future for flexible ureteroscopy to do even better than what we are doing today, what do we need? We need new endoscopes. There's no discussion on that. We know exactly what we can do and what we cannot do with the regular endoscopes. We need better laser, and we need better laser, especially to go finer, because if we go finer, then we can imagine to aspirate the fragments, something not so easy when we are using holmium YAG, as you know, much easier if we are using thulium fiber, because thulium fiber, and that's the beauty of thulium fiber, it generates very thin dust. That's the main benefit compared to holmium. Of course, we would like also to go faster. And this is another issue, but we need to save time because this procedure is time consuming, as you know. But the most important part is vacuum cleaner. If we would like to do better than PCNL and to compete with PCNL, we really need new equipment able to remove immediately at the time of the surgery all the tiny fragments and the dust to have a stone-free patient and not to be forced to wait a few weeks to have a better stone-free rate. So we need a vacuum cleaner, we need suction to aspirate. Something we can now imagine, since the introduction in 2016 of the first single-use digital flexible ureteroscope, this technology opens the door to imagine new system to aspirate this dust. If we consider the problem in 2024 regarding flexible ureteroscopy, we have 4 problems. The main one is the residual fragments and all the dust that we are producing, meaning that the patient is not stone-free at the end of the procedure. And it's also a problem because with the many fragments and dust, the quality of vision is not excellent. So we cannot go so fast as we would like. We have also the problem of high temperature because we are using laser. They are more and more powerful, and people are using this power. Probably sometimes it's a bit too excessive. It generates, as you know, thermal damage, and this is a big problem actually. And of course, the problem of intrarenal pressure that we have already mentioned before. And if we think about these 4 problems, we need to realize that there is one easy solution, suction. If you have suction, you will aspirate the dust and the fragments, patient will be stone-free, vision will be better, we will manage the temperature and of course the pressure. So 4 problems, 1 solution. Easy to understand. Regarding quality of vision, as we said, we improve a lot the quality of our optics. So that's also why we are saving time. But still, when we have this snowstorm effect, this is something that we don't really like during the procedure. So we need to improve the quality of vision regarding using some specific section. Laser and safety, that's this problem I mentioned before, the thermal damage, and you know this ureteral stenosis. We have more and more problem with the ureteral stenosis, and it's due to the use of laser. It's not because we have more and more impacted stones. We still have, but the main problem is the malpractice regarding a laser, because you know that when you're using too much power, that's because you are using too much frequency. It's impossible to have high power with low frequency. It's not because of energy, but because when you set the laser with high frequency, you increase the total power. Doing that, 2 possible problems. With very high power, I would say 25, 30, 40 watts, even more. The problem is that you heat the irrigation. And we have a lot of data actually published to demonstrate that with more than 20 watts into the kidney, there is a big risk to increase the temperature. The second problem is that since you are using high power with high frequency, you have much more pulses, And due to much more pulses per second, you are losing some of the pulses away from the stone. And away from the stone means that you will damage directly the mucosa. So you have direct lesion, and that's the main mechanism actually into the ureter to produce this ureteral stenosis that we know. We have a lot of reports on that. We have official reports, even recall, to explain that using high power, high frequency is very dangerous, especially for the ureter. We have also this data from 2017. You see that in this publication, the author said that if you're using low power, like 5 to 10 watts, even you have a minimal irrigation, 7, 8 milliliter per minute, you have no problem in terms of thermal damage. You have problem only if you have 0 milliliter per minute. It's not the case. Usually we have an average of 20 milliliter per minute. So this setting is very safe. But if you are increasing the setting because you increase the frequency, so the total power, now it becomes dangerous. And if you don't generate a flow more than 40 milliliter per minute, then you are not safe. And it's very complicated actually to produce 40 milliliter per minute if you are not able to evacuate. If the outflow is not comparable to the inflow, it's impossible to have this kind of flow. And of course, it's even more dangerous if you keep the laser on all the time. We have different data publication to explain that more than 20 watts is very dangerous. The one from the Nordic colleague, Ulvik, or the one from a Genio Ventimiglia from Italy, they all demonstrate that into the kidney, we must not use more than 20 watts and less than 10 in the ureter. Regarding irrigation and pressure, think about that. When you are using, like this example, 110 millimeters of mercury, so it means 1.5 meter of water. That's what you do in terms of irrigation when you're using this pressure bag. Until you have a good outflow, maybe it's okay, it's safe. But if you have a very bad outflow, as we have seen before, then you generate super high pressure. So to irrigate the kidney, we must recommend to use low pressure to irrigate. And then it's much, much safer. Need a good irrigation, as we said, if we would like to increase the inflow, to have a better visibility or to refresh the system due to temperature, we need also to increase the outflow. Otherwise, if we don't do that, we also increase the intrarenal pressure. It's a compromise. We cannot do one thing without considering other parameters. Fragmentation and basketing is probably the ideal to have a stone-free patient, to have a complete stone removal. The problem is, as you know, it's an exponential process, it's very complicated, and most of us, we much prefer to do full dusting. Much easier, we stain to the kidney, there's nothing to remove if you produce only dust. So the dusting is probably the main technique actually that we need to accept. Also because we know that the dust, when it's super light, super small, it evacuates. It evacuates during the procedure and just after the procedure. Only the tiny fragments, they will stay into the kidney. Problem is that we have no idea about what is the definition of dust. All the people said, I'm dusting. Okay, but what do you produce? Do you know exactly the definition? Nobody knows. We have no clear definition of dust. And it's very important to know this definition, to have a clear definition. To know what we can aspirate, we need to know what we would like to produce. And that's why we produce this definition according to different parameters. The most important one was that the quality of the dust must be, we must be able to aspirate using a 3.6 French working channel, which is the regular channel that we're using actually, 3.6. So we evaluate what was possible to aspirate with this channel. And we conclude that if the particles are less than 250 microns, it's possible to completely aspirate the dust. But of course, since we know now that less than 250 something we can aspirate using 3.6, we need also to have a special equipment to produce the dust. And that's what we know actually with the thulium fiber. The thulium fiber is the only laser able to produce dust less than 250 according to all the stone types. So knowing that, many people start to evaluate if it was possible by producing the dust and to aspirate. And as you know, we have three systems. We already mentioned that. You can use this bendable ureteral access sheath like the Clearpetra. We can use a direct in-scope suction, or we can use special system who are not a ureteral access sheath or an endoscope. And the typical example is the CVAC, actually available in the States. Regarding the ureteral access sheath, as you know, Professor Zheng, he was the first one in the world to design and to use a rigid one into the ureter. And he demonstrated that it was working very well into the ureter, but of course, not excellent for the kidney. So that's why a new evolution came in 2022, this bendable suction ureteral access sheath, what we call the fans. Now it's articulate. We have different diameters, 10, 12, 12, 14, even less, actually, able to navigate into the kidney together with a scarp that you can irrigate and aspirate at the same time and laser at the same time. And we must say that it works. And all of us, we have good examples, good experience, actually, to explain that it's feasible. But we need also to be honest. It's not a solution which working all the time. We cannot say today that this is a systematic instrument that we are using for all patients, because for some patients it's not suitable. Or we have still questions regarding the accessibility in very tight ureter, narrow collecting system. We have also some concern actually regarding the safety. It's not an easy instrument to be used. You need to know a lot of tips and tricks. And think about all the urologists. We will have to do a lot of teaching for that. So the system works, but the system is not ideal actually. Suction with ureteroscope. We all know that it's possible because in our practice, we all use syringe to aspirate some urine and to gather some fragments, some dust. We know it's possible to do that. There's no discussion on that. So of course, as you know, the Indian colleague, they designed this direct in-scope suction. And this is a second concept to aspirate. And now we have also companies who are producing commercially endoscope together with a button that we can activate to aspirate. We know it exists, but keep in mind that this system is using just a regular working channel that you can irrigate or you can aspirate, but you cannot do together at the same time irrigation and aspiration because this is just one single working channel. But at least it demonstrates that we can aspirate part of the dust. And what's the main problem of the DIS? That's the size of the fragments. If you aspirate bigger fragments, and Clement demonstrate that you will have a lot of blockage into the working channel. And it's exactly what we demonstrate if you aspirate particle more than 250 microns, okay? And this is something more complicated. So the second evolution for the DIS is to increase the size of the channel. But if you do this, you also increase the external size of the scarp. And this is, again, another compromise. The problem is that with this kind of system, you will have maybe less blockage for some parts of the fragments, but we still have a blockage actually with this kind of endoscope. And since the working channel is 5.1 French, much bigger, you need to aspirate much more, so you need to irrigate much more. And again, it's another compromise, not easy to manage. The CVAC, you know, the first evolution, it was a blind system that we need to use with a fluoroscopy. It was completely blind. It was a bit dangerous because if you were aspirating the mucosa, there's a big risk of bleeding. So this one is not available anymore. And now we have the CVAC, the second generation, Calypso. And you know this system, it's not an endoscope, it's not an access sheet, it's a coaxial tube. You irrigate externally and you aspirate from the middle. What about the problem? It's a big instrument, really big, and you need to go through the UPJ. The second problem is that you cannot irrigate and laser and aspirate at the same time. You need to do the laser treatment before, then you remove the fiber, the laser, and then you aspirate. And this is something probably not easy to manage, and you have no control about the pressure. So if you make a review about all the different systems, we can just conclude that some systems are available actually. It works to demonstrate that suction is possible, but we need also to tell that there is no ideal system that we can use for all the patients. So let's think about this ultimate solution. What does it mean? It must be a special endoscope, of course. Why? Because we need to have endoscopic vision. We need to manipulate to go everywhere. We need to have the access to the kidney, and we need to respect the anatomy. So the system is supposed to be less than 10 French. The system must integrate irrigation and aspiration at the same time and need to consider the intrarenal pressure. So we need to record the pressure to adjust irrigation and aspiration at the same time. The system must include laser, otherwise you cannot produce the dust. So the system needs to work together with a laser. And this is the most tricky part, the system must automatically detect stone blockage regarding the fragments. And if it detects some blockage, you need also automatically to unblock the system. Otherwise, you will not be able to proceed. So this is 10 points, main points, to imagine this ultimate system. Does it exist actually? If we look at the system available, if we check the 10 criteria, no. We cannot say that only one system actually fits with all these 10 parameters. So we need just to imagine this system like a full integrated solution. But the full integrated solution is not what some people are telling you today. Irrigation, aspiration, and pressure. No, this is irrigation, aspiration, pressure, laser, endoscopes, and system to unblock if the system is blocked. This is what we call the full integrated solution. This is not only the irrigation. And of course, if you imagine such kind of system, I can just tell you in the lab, and that's what we are doing since now 7 years, I can tell you that the system works very well in the lab. It's possible to design such kind of system to aspirate, irrigate, laser, control the pressure at the same time, and it works very well. We also designed this system like a prototype that we test actually in the real life with 12 patients, and I can tell you that the system also works and make the procedure much more simple compared to what we are doing today, because all the fragments are coming directly to the tip of the scalp. So much easier actually to do this procedure, going much faster, because we can use now high power, because we are not afraid regarding the increase of temperature. The vision is excellent, so we can go really much faster. And that's when we perform this clinical evaluation with 12 patients, I can tell you that all the patients were stone-free after the 1-day surgery. You see just one example. You see plenty of residual fragments, big one, big volume, 5,300 after a PCNL. The yellow tube is the nephrostomy tube in place. And look, the day after, when we were using this new system, fully integrate, the patient was completely stone-free, and we were able to aspirate all the dust. I hope that you will be able to come to this also this meeting after the meeting in Phoenix for the World Congress in September. Maybe you will have more time and you will come in November in Roma because the EAU endourology organized a big meeting on endourology. And I hope that I will be able to present more data on this new ultimate solution for a section. Thank you.